Hi all and a very warm welcome from MMP. This video is designated to burst some procedural myths regarding primary total hip replacement and find out the mysteries surrounding the causes of failure of hip reconstruction. We will discuss some practical methods to overcome the limitations leading to failures. This video is strictly recommended only for those who are doing actively the total hip replacement by themselves and would like to learn about the intricacies of the procedure. We know that total hip replacement is considered one of the most successful and cost-effective surgical procedures, primarily considering the endpoints of pain relief and functional restoration. So it was called the operation of century in 2007. However, there have been concerns regarding loosening, instability and wear causing failure of the hip reconstruction, for which continuous improvements are being sought. Let's dive into understand them. To understand the various intricacies of the total hip replacement, this video is divided into different sections. The various aspects that we would like to cover in this video are the myths and mysteries and practicalities, what I call MMPs, of the approach towards the total hip replacement. Then we will go into whether we should use a cemented or an uncemented implant and their various combinations like the hybrid or the reverse hybrid. Then we will understand the various femoral side MMPs in the form of different and the variety of stems available and their specific usage, their rationale, their success, why they failed, what is the designing change that they are constantly undergoing, and which one is more successful. We will also try to define which stem to choose for a particular case. What is the role of the spinopelvic alignment on the acetabular side fixation? Because acetabular side fixation is one of the most, I would say, the chicken neck of the total hip replacement. Then we will understand the various engineering aspects of total hip arthroplasty with regards to the biomaterials used, and also we will delve into the robotics and their use in total hip arthroplasty. For the purpose of doing hip reconstruction, primarily three approaches have been described, namely the posterior or the posterolateral and its modifications, the anterior, and the lateral or the direct lateral or interlateral approach. The superior or the superpath has been recently described. As far as the posterior approach is concerned, we know we have a very long experience and most of the surgeons have been very comfortable using this approach. The only bad thing or the bad repetition to this approach was the high dislocation rate, but that has also improved over a period of time with the better understanding of the soft tissues and their dynamic relationship to the hip joint movement, especially the capsular closure. This approach is abductor mechanism preserving approach and is very good for the extensile exposure needed in cases of difficult primary and revision total hip arthroplasties. Because of the poor reputation regarding the high dislocation rate of the posterior approach, direct lateral approach or interlateral approach became very popular, and I would agree that this approach has the least dislocation rate for total hip arthroplasty, but it has got a primary disadvantage of a persistent abductor lurch because it goes through the gluteus medius, and because this plane is violated, there is a higher incidence of heterotopic ossification also. Direct anterior approach has got the highest rising popularity and most of the surgeons are shifting towards this approach. This approach is also good as regards the exposure of acetabulum, especially because the patient is kept supine, so the position of acetabulum is not changed. The only problem with this approach was in the initial period when the approach was being developed and used by various surgeons, there were high incidences of femoral fractures, increased blood loss, and damage to the femoral cutaneous nerve. Also, in obese patients, there was high incidence of SSI, reported surgical site infection. That made this approach a bit dicey for others to accept it, but I agree that with the increasing experience, this approach is gaining more popularity and the complication rates have reduced a lot. But my MMP analysis says don't change your winning game. If you like the posterior approach and you are very comfortable using it, then continue using the posterior approach. If you want to learn newer ones, maybe direct anterior approach is a good one. And if you have become more comfortable with the anterior approach or the lateral approach, continue using them. But my word would be like for complicated revision and complicated primary total hip replacement also, posterior approach might serve better advantage regarding the exposure of acetabulum. Using a cemented or an uncemented hip is a very highly debated topic. especially because once we understand the chronology of the evolution of total hip replacement, we would understand why we should be using one or the other implant. Basically, the total hip arthroplasty developed as an interposition arthroplasty which had primary failure. It was an uncemented attempt. Then came the hemiarthroplasty in the form of Austin Moore prosthesis that was again uncemented. Then we have cemented Thompson prosthesis. Both of these are more or less a failure and now not being used at all. Then came the successful era of total hip arthroplasty, and that was a cemented total hip replacement. Somehow, this was described somewhere in 1960s, but somehow in 1980s, a new concept of cement disease came up, which portended like there is a lot of osteolysis because of the use of cement. But now we have come to know that it is a persistent granulomatous reaction to the wear particles of UHMPE and has nothing to do with the cement particles. But this cement disease was so fearful because of the persistent failures which we have met in the past for total hip arthroplasty that we started looking for uncemented biologically fixing implants. Now, uncemented implants could not really prove the or surpass the success rate of the cemented arthroplasty. So we have further modifications and lots of them, to the extent that we have gone to surface replacement arthroplasty, which is sort of a form of interposition arthroplasty. So we have crossed the whole circle back, and then surface replacement again failed. Now we have to justify why we introduced uncemented implants. Now, the justification is that although cemented is successful over a long period of time, but we know that cemented hips keep diminishing over a period of time. That is true. They are not biologically fixed. So they have ultimately a limited lifespan only, which may be 15 years or maybe 20 years, but they keep losing their life over a period of time. So biological fixation is always better and is the hallmark of uncemented processes, based on which we still assume that uncemented will be the future. From my description, it would appear that I am more biased towards cemented total hip replacement. It is not so. I do lots of uncemented ones, and I would like to prove why uncemented ones are improving now. We should basically understand a few of the design considerations of the cemented and uncemented stems or the arthroplasties. Uncemented total hip replacement is a revolution. It has introduced lots and lots of biomaterials for our disposal, but we need to understand that there should be biosafety and biofunctionality with respect to those implant materials which we are using. Biosafety is what the implant does to our body. Biofunctionality is how well it gets incorporated in the body. So basically, it is the body's reaction, how well it is accepted in the implant. Cemented arthroplasties are known for failure through the mechanism of osteolysis, while uncemented one have the biggest and had the biggest drawback in terms of stress shielding, especially the femoral stem, not the acetabular cup. The cemented stems are available basically in two different models, the taper slip or the composite beam. We in India mostly are using this collarless form of taper slip model. Shape closed was the classical Charnley stem and has been popular in Europe with other modifications. Cemented cups are usually flanged or non-flanged. Nowadays, non-flanged are being used increasingly. Flanged was to increase the pressurization of the cement, but no specific advantage has been found with that. The uncemented stems, as I told, it is a revolution. They are available in various shapes, various lengths, long, conventional, short, ultra short. All of them have their own pros and cons to be used. And currently the short stems are in vogue. Then the surface engineering is one of the very important aspects, how to biologically incorporate the implant into the bone, whether to ungrow the bone on the implant or whether the bone should grow into the implant, and there are lots of modifications. That is what costs this implant a lot, because a lot of research is going on into this implant. Once the standardization is done, the cost would come down, and I'm sure currently the success rate is as good as the cemented one also. So it may become the world favorite in the near future. So based on the various registries, the randomized control trials and the meta-analysis, I have compiled this table considering the all-cause revision rate and the cost effectiveness as the endpoint of all these data. to compare the cemented, uncemented hybrid and the reverse hybrid ones. We need, what comes out is that most of the studies and the registries say that the survival rates of the cemented arthroplasty uh, is the best, especially in the age group more than 65 years of age. This cemented hip replacement is the implant of choice for DAW type C femur, which is a long funnel. There is no funnelization in the femur, and the uncemented implant will not fit. The current designs of the uncemented implant will not be fitting in it. This is also seen in the osteoporotic bones. Also, in the irradiated bone, the biology is very deficient, so that the uncemented implant, which is based on the biological fixation, will also not work. If you need antibiotic delivery, then also the cemented implant has to be used. Femoral impassion grafting has shown high failure rates with the uncemented implant, so cemented implant is again a choice for them. The advantage is that during the surgery you can customize the intraoperative offset and the version. The revision is also easy, especially the cement and cement revision. Before that, the removal of cement was a big headache, but the cement and cement revision has made the life easy. This is a cheaper implant. The disadvantage is the BCIS, bone cement implantation syndrome, which may be because of the unpolymerized methyl methacrylate particles or the embolization, but it is a very poorly understood phenomenon. The implant failure or the implant fracture of cemented implants is a very known complication. It is unique to the cemented implants because they are thinner. And one of the RCTs has said that the males less than 65 years fare very poorly with cemented implants. The uncemented implant, on the other hand, is a very developing implant. It is still trying to find superiority, but in any case, doesn't seem to be very inferior. Although nearly all the registries have reported high all-cause revision rates. But this is not for the femoral stem. It is femoral. This is for the acetabular cup that the uncemented implants have really outperformed the cemented implants. So if you want to use uncemented implant, then the uncemented cup is possibly the good choice, whereas cemented femoral stem would be a persistent choice. I mean, it has not shown that much that big a failure. That's how the concept of hybrid implant has come up. The uncemented implant is recommended for age less than 65 years. Some registries say that age less than 55 years patient fare much better with uncemented implant. Obviously, they have better biology. I would also say that the high volume centers can switch to uncemented implant because it is time saving. We don't need time or waste time for cement to cure. Also, it offers biological fixation and would last very long. It will not deteriorate over a period of time. And non-RCT trials obviously support the uncemented implant. Maybe when this data gets captured into the registries, the success rate of the uncemented implants would improve. As told that the hybrid implant is based on the concept of better surviving uncemented cup and better surviving cemented femur. So if you combine both of them, then you will get the best result. But unfortunately, except for from possibly the New Zealand registry, which supports use of hybrid implants as the one of the best implant constructs, the philosophy has not become very universal. The uncemented cuffs have also found to have very high failure rates, especially in the Swedish register and patients more than 75 years of age. Whereas the proximally coated uncemented femur has better osteolysis profile, so you can use a uncemented stem instead. Also, one of the studies which considered 4,450 patients said that the cemented cup is the gold standard for non-obese females. So the concept of hybrid is not very much supported. Reverse hybrid is a special situation, especially in the cases where there are large cysts and dysplastic acetabulum, where we would need to use a cemented cup because the uncemented cup may not have a very good hold. Whereas we know that the proximally coated uncemented femur has better osteolysis profile, so you can use that on the femoral side. So it becomes a reverse hybrid implant. In any case, based on all this analysis, I would recommend that younger patients less than 65 or less than 55 would fare much better with respect to the newer and improved uncemented implants. However, the cemented implant is still the choice in patients more than 65 years of age. That is how you can basically decide your implant choice for total arthroplasty. The femoral stem cell controversies primarily pertain towards the uncemented implants, whereby we are trying to improve the biomaterial and the stem shape and the stem length. Because of the busyness of this slide, I had to switch off my video. The biomaterials have changed from the stainless steel to titanium. Then titanium has been withdrawn because of high failure rate and the trianosis. The stainless steel, which is considered nowadays is the best or the most optimum implant, and even the 316L has fallen out of favor. Whereas what we nowadays rely on is the austenitic and yield biodegradable M6 stainless steel. The titanium also had the problem of the aluminium and the vanadium, both are toxic to the body. So a low aluminum vanadium implant is getting available, which also has a better modulus of elasticity than the stainless steel. Now the composite materials are falling into favor because the elastic modulus of the bone is much less than the available uncemented implants. The bone elastic modulus is somewhere in the range of 20, whereas the titanium is somewhere around 70, while the stainless steel is 85 to 90. So we have improved material like carbon fiber reinforced polysulfone plus titanium that can also be manufactured using additive manufacturing or 3D printing. The implant which is being very actively studied is the polyamide 12 continuous carbon fiber implant, which has modulus of elasticity same as that of the bone. But we know that the bone doesn't have modulus of elasticity same at every part. The cortical bone has different, the cancellous has different, even at the trochanteric level it is different, and the shaft is different. So we need functionally gradient materials whereby we can combine titanium proximally and we can give the carbon fiber composite distally to match the normal modulus of elasticity of the femoral stem. Regarding the stem shape, the curved stems have fallen out of favor and they have been retired. The stem of choice is the straight, cemented or uncemented both in femoral stem. The stress shielding is least for rectangular implants, and even it is lesser for porous and FGM, which is the functionally graded material implants. Now the current controversy lies with respect to the stem length, which one should be used. The longer stems are only for revision; they should never be used for primary, unless until the bone in a specific case where we don't find any proximal metaphyseal fit. The standard length implants have been in vogue for long, but they have not uh, really proven long-term benefits. So it has been found that the inflection point for the length of the implant comes at 143 millimeter. Longer than that or shorter than that leads to stress concentration. And in general, the longer stems have higher initial stability, but they also have much higher stress shielding. The shorter stems, like this delta stem, they have less stress shielding, but they cause lot of stress concentration. So the optimal length has been proposed to be 100 and 133 millimeter stems, which are these modern stems, proximally coated short stems, and they are in vogue for the uncemented femoral side fixation. Now, with regard to the global offset and the version adjustment using femoral stem, this is a known fact that for cemented implants, it is a bit more easier by sinking or keeping the stem a bit proud. You can change the global offset. Also, you can rotate the femoral stem while insertion to improve the version which you are aiming and which we have tried. Now, for the uncemented implant, unless until you are doing a femoral stem first technique, it is very difficult to adjust the version because the femoral stem fits into the bone, native bone. And unless you have a very high modular system like a SRAM system, it is nearly impossible to adjust the global offset and version in case of an uncemented stem. Acetabular fixation is the chicken neck of total hip arthroplasty. Most of the failure mechanisms of total hip arthroplasties are related to the acetabular side fixation, and poor purchase of the cup. This is mainly because we have carried over the concept of medialization of the cup from Charley's low friction arthroplasty. We should remember that Charley used a cemented cup for which medialization was required. Anatomical acetabulum is not a hemisphere, and to fix a cemented cup into it, we needed medialization so that it gets a circumferential fit and circumferential mantle. But if we carry over the concept to uncemented cup, and we medialize it by doing more reaming, what will happen is that you don't know how many millimeters we have gone inside. Now, when we have gone inside, you don't know how to restore the femoral offset. We measure the femoral offset from the center of the femoral head to the tip of trochanter, which is fixed, but we have medialized the cup. And if we restore the native femoral offset, that means the exact distance between the center of the femoral head to the trochanter tip, that means the global offset will get reduced. If it is reduced, it leads to bony impingement, microseparation of the components that lead to failure, especially in case of hard-on-hard bearing. There is increased wear and there is less bone available while doing revision. There is also altered working length of gluteus medius that causes change in proprioception and lurch. So the best way to overcome the situation is to improve the global offset. But it is really unknown because the medialization is unknown, so you don't know how to restore the global offset to the normal anatomical position. But if you do it, and this is where the experience of a uncemented hip arthroplasty surgeon comes in. If you can really restore it, then the stresses on the bearing surfaces are the least and the hip will survive for a very long time, and also maintain the abductor lever arm so that the gait will also be as normal as possible. If if you do medialization and you put a reduced global offset, then it is a catastrophe. It is bound to fail. So now we already know that medialization of the cup is a myth, and if you medialize the cup, then it leads to impingement. It can be between component and component, bone to bone, or component to bone. It gets exaggerated if we do not remove the osteophytes. Now, if you medialize and the offset is not restored, usually what happens during medialization, there is also alteration in the height of the acetabular component and of the overall implantation. This reduces range of motion, and the decreased global offset and length causes failure of the abductor mechanism. Unfortunately, this cannot be restored by even increasing the femoral offset or even osteophyte removal. It has been found practically. So try to restore the offset by not medializing the cup and putting the implant in the as anatomical position as possible. There is also a possibility of lateralizing the cup. If you lateralize the cup, then it leads to lateral uncoverage and increases the impingement of the femoral neck to the cup liner, causing the liner failure, edge loading, and obviously ultimately fracture or dislocation, or even the acetabular component as a whole may come off. The current practicality for doing the MMP analysis, the current practicality is to restore the anatomical center of rotation of the uncemented cups. If you medialize them too much, they will also lose their rim cortical fit. So the initial stability would be at stake and the implant may fail. Although over a period of long time, if it survives, then it may gain bony in growth and hence the stability. But the initial stability will always be dicey. If you lateralize the cup, then obviously there is loss of superolateral bony support. Cemented cup definitely needs medialization for containment, and as we have discussed, it can be sort of partially offset by increasing or increasing the femoral offset in the cemented implants. In the last slide, the concept of cup height was highlighted. With increased medialization, there is also increase in the height of implanting the cup that leads to shortening, increased joint reaction forces, and premature wear, leading to ultimate failure of the implant. Inferomedial cup positioning is recommended. If you cannot put it inferior, then at least do not change the anatomical height of the cup. What was classically thought and classically propounded was that the up to 13 millimeter of superior displacement of the cup and 7.5 millimeter of medialization is acceptable, but it has been found that more than 3 millimeter rise in the height of cup and more than 5 millimeter medialization of the implant, if that is done, then it is very difficult to restore the offset and the mechanics. Biomechanics cannot be changed and should not be changed of the hip. Then the mechanism of the hip cannot be restored, and there will be one or the other component of failure present in your total hip reconstruction, which we have already done. So restoring the anatomical center of rotation is the best while doing an uncemented total hip replacement. This is why now the main focus is putting the uncemented hip in the anatomical position. Positioning the acetabular cup in correct angulation is one of the most difficult aspects of the surgery which involves putting the acetabulum in correct inclination and anteversion. Some people combine them together to call it anti-inclination. The inclination of the cup is with respect to the coronal plane. If you increase the inclination, then it leads to edge loading and further wear. Whereas if you decrease the inclination, it leads to impingement, especially in the abduction and standing position. This leads to increased dislocation rates. Same goes for the anteversion. Beyond a range of 5 to 25 degrees, there is increased wear and squeaking, which is seen with the ceramic on ceramic bearings. To add to the confusion is the fact that the positioning of the cup also changes with respect to the kinematic position of the hip joint. There is increase in the inclination with anterior pelvic tilt, but it is very insignificant. The major change occurs in the anteversion, which increases from supine to standing and further increases on the sitting position. Now, there is a total change in the anteversion of 15.6 degrees from sitting to standing, or standing to sitting. Actually, it increases in sitting position. Now, the biggest problem is that we already have a very tight range for anteversion. So this change is bound to cause some sort of impingement and may predispose to the failure. For these things, some generic safe zones have been proposed as above, but the mystery is 50% of the hips lie outside the safe zones, but not all of them dislocate. And the other thing is that most of the hips that dislocate have been found to be within the safe zones, even in the Levenick original paper itself. For just theoretical purpose, we should remember that operative inclination of vestibular cup should be somewhere around 39 degrees, whereas the anteversion should be somewhere around 21 degrees. The operative inclination is less than the radiographic inclination target, whereas the operative anteversion target is more than the radiographic anteversion target. Now we come to the practicalities of improving the acetabular positioning. Templating of acetabulum is a must. Never use it to size the acetabulum, but in fact use it to properly position the acetabular cup and find the center of rotation. The inferior point of the acetabular cup is not at the tear drop, it is a myth. It is at a point which lies between the inferior margin of posterior acetabular rim and the tear drop. Also, you can use the lateral margin of the acetabular cup and the distance from the cup margin to the native acetabulum as one of the markers that can be easily reproduced intraoperatively also. Using conventional jigs and eyeballing with it, pointing it to some or the other corner of the room or to the floor or to the table or to the roof is mostly unreliable and does not yield very good results. It has been a bit improved by using spirit levels and lasers, but they are too cumbersome and not available. The other operative measures to improve the acetabular positioning is using navigation. Use it, especially if you are using the lateral operating position, because that is totally unreliable. Navigation helps to improve the identification of the bony landmass and also the component positioning. The other very good landmark is the TAL index. It has been repeatedly proven to improve the acetabular anteversion and also to some extent the inclination. I think inclination can be very well judged by using the transverse acetabular ligament. There is also some help from the TAL index in improving the acetabular depth also. The one of the very good markers, instead of just putting the acetabulum in good anteversion, is to use the combined anteversion as proposed by Dr. Ranawat, and it should lie somewhere between 30 to 50 degrees, but for Asian population it is a bit less, somewhere around 20-25 degrees. Also try to bury the cup anteriorly so that it doesn't impinge the psoas tendon, and this also helps in improving the anteversion of the cup. Spinopelvic interaction has gained too much airtime in the current years. It is too complex a topic to understand for an average orthopedic surgeon, especially those who are not dealing with the spine surgeries. I don't know the real reason why it has been so complicated, but and also I don't understand the real reason what we will gain by understanding the spinopelvic interactions, how many dislocations we can really prevent. To simplify the topic, if we don't want to go into the depth, then I have just few conclusions that I have made from a lot of readings from that. If you have a fixed balanced spine, then target your generic safe zones. Although I said that these generic safe zones are not really good guides, but the fact of the matter is that nobody has put their acetabulum way beyond the generic safe zones, even after understanding the spinopelvic interaction. So they definitely have some or the other credential. So always remember, that's why I have highlighted them in the previous slides. If the spinopelvic interaction is too stiff, that means the spine is stiff, keep it in anteversion and inclination on the higher side. If it is a hypermobile spine, then try to keep the anteversion inclination on the lower side. Whenever you are in doubt, use large head or anti-dislocation cup or dual mobility cups. That would come to your rescue in every situation. Or otherwise, send the patient for first spine evaluation and spine surgery if needed. And if that gets balanced or compensated, then you go ahead with the normal target generic safe zones and do your arthroplasty. One thing to remember, if you want to understand the complexity and make it simple, is the fact that while sitting, there is posterior pelvic tilt that leads to increased acetabular version. Just remember one thing. And this situation would change depending on the situation of the spine, if it is stiff or if it is flexible. And this is superaddedly changed by whether your hip is stiff or flexible. So there are 6 different categories possible with normal, abnormal, and hyperflexible spine, and same way normal, stiff, or flexible hip. Now the spine problems predominate, so we use the term stiff or flexible with respect to the spine and not with respect to the hip. If it is a stiff spine, pelvis may go into a stuck sitting position and there will be reduced version. Or if it is in stuck standing position, then there is increased acetabular version, and you have to reproduce that particular situation. The topic will be a different lecture altogether, but this is the crux of the topic of the scenario on the spinopelvic interaction. Maybe I will post a different video for completely understanding the spinopelvic interaction to make this topic a bit more easier. But for the primary total hip replacement surgeons, this is all what we need to know. The last 3 slides are basically dedicated to the engineering aspect of total hip arthroplasty. So for surgeons, they do not really make much of a difference unless until you want to really go in for robotics, because with them come some tools which can preoperatively identify your spinopelvic relationship. Also, intraoperatively, they provide wonderful navigation for the assessment of correct acetabular plane and version, while you have a very poor lateral position to do a hip arthroplasty. And robotics also help in accurate placement of the implant in desired position. But the problem remains is that you don't know that today we are talking about kinetically balanced total hip replacement. So how much good is this accurate positioning by using robotics is going to help clinically? That is what is reflected in the studies, that there is no clinical or functional superiority of a robotically performed surgery compared to the manual surgeries. Additive manufacturing or 3D printing has been started in total hip arthroplasty also with respect to the ceramicizing the bearing surface, and also the femoral stem, where we already discussed FGM. That means the different modulus of elasticity stems to match the native femur. So that has come in a way, but it is still under study and may become the master stroke if it really proves to be of real benefit. The biomaterial and bioactivity definitions are very complex, but in any case, the biomaterial means any material which is biocompatible and can replace the biological tissues. Bioactivity is its effect on the native tissues and the effect of native tissues on the material. We know that we have two different types of bearing available at this moment, which is hard on soft and hard on hard. Metal on poly is the classical hard on soft bearing, which is the gold standard for comparison. Ceramic on poly has got similar results. Nobody has proven a direct superiority of this bearing, but yes, it is in vogue. The problem is the cost. It is a bit costly bearing. Hard on hard, the only surviving one is the ceramic on ceramic bearing. Metal on ceramic has also been recently proven to be failed. The improvements in biomaterials and bearing surfaces can be basically divided into 3 different headings of polymers, metals, and surface modifications. Lots of polymers are available. PTFE, polytetrafluoroethylene, has already failed. So the UHMP came up into vogue, which changed to cross-linked poly, which has changed to highly cross-linked poly, and now we have vitamin E poly. PEEK has shown very good results, but there is no commercialization. I don't know why the companies are not finding any place for it. Then we have a super lubrication material, difficult to pronounce. It is PMPC, poly-2-methacryloyl oxyethyl phosphorylcholine. Difficult for me also. So this has proved to improve the life of the cross-linked polyethylene and reduce the wear rate tremendously. We have polycarbonate urethane, PCU, which is a compliant or a cushion bearing. The only problem is that the femoral head may sink into the bearing itself, but it has very low friction. Some improvements may make this bearing a real practical one. Metals we have already discussed. The surface modifications are the newer ones, of which the silicon nitride coating and the sapphire are the two ongoing and the most studied materials. The other ones have slowly fallen out of favor and are not being pursued any further even in the engineering realm. So the final MMP of total hip arthroplasty. It is a very good and very successful surgery, but we are still far from perfection. We need to improve a lot. There is no universal implant or technique available to provide the best course for your patient and say that this is the only thing which is available, which will be done, which is cost effective, mass produced, commercialized. There are lots and lots of permutations and combinations available. You can still customize the implant based on your own experience and the availability and the patient specific conditions. That's why you need to learn all of them, but choose wisely so that it doesn't hurt the patient clinically and also on his pocket. Ultimately, despite learning everything, you need to master one or two techniques which will provide patient the best result and the outcome. Thank you.